everything the way you were told and still not get it right. Still have those unexpected lows in the middle of the day, in the middle of work, or in a social gathering that's gonna be awkward, that's gonna ruin your moment, or be at work when you don't want anybody else to find out that you have diabetes, let alone that you're having a severe reaction. It could be frustrating that you think that you really became an expert in carb counting and you could still go to a restaurant and get it wrong. Or having in some cases complications when people who've had diabetes for a very long time, again, despite trying. So I think those are the more day-to-day frustration that comes to mind. Sometimes it's you wonder why you would have to deal with this. I think we see it more in adolescence, or even people go through phases of wanting to give up and not having to deal with it, or at least maybe have a break from it, even for a day, even for hours. But the reality is we never get a break from it. It's always there. So I think that's the most frustrating part.
So Dr. Moosavi, would you be willing to share a more recent incident where you had a low, totally unexpected, and it was something that was very inconvenient anytime in the past year, like a real situation?
Yeah, for sure. So I think for me, the most sort of challenging lows, if they happen in the middle of the night, just because I guess a lot of people can relate to that. And you wake up and you feel awful, and you're trying to raise your blood sugar as soon as possible because you think you're going to faint or you're going to have a seizure. Then you're overcorrected, and then you're high in the morning, and it basically is a sort of phenomena that it ruins your entire day the next day, because you're struggling with the highs, and then you're low again, and then you're high again. So it's I would say that's been my latest experience of just miscalculating like a dinner at a restaurant, and then finding myself at 2.2 and 3 o'clock in the morning, and trying to get to the kitchen and trying to just basically eat everything in the fridge to raise my sugar, because as everybody knows, it feels awful to be that low. And then you feel off the next day. You feel that you're not yourself. You feel weak. So I would say that was the most recent incident I've had.
Okay. And I know you weren't diagnosed as a kid. Would you be willing to talk about when you were diagnosed and how you reacted, what it was like for you, your diagnosis story?
Sure. So I was diagnosed at 21, and I was actually preparing to get into med school at that point, and it was a summer that I was studying a lot. And strangely enough, I was volunteering in a diabetes center in Montreal, in Montreal General Hospital, and I was working with an endocrinologist who later became my endocrinologist. So I just had all the symptoms of losing weight and being very thirsty, and waking up in the middle of the night to go to the bathroom, blurry vision. And then at some point, I just decided that I need to go in, and initially the doctor that I saw in a walk-in clinic thought that I was too old to be type 1. So I was started on metformin for type 2 diabetes. And then shortly I felt really sick, and I ended up in emergency room, and I met my endocrinologist, who was Dr. Markovitz, who just came and basically injected me with insulin right there. And then that's the path, and the journey started right from there. But it was interesting because I ended up working with them. I ended up doing research with them. And then she obviously was a big influencer for me to go into endocrinology, because both of interest and also being able to relate to patients personally.
Okay. All right. So question number 2, what do you worry about the most with regard to living with diabetes? Worry, I mean, when I talk about worry, it could be long-term, 20 years from now, but what are your biggest worries?
I would say, I think, I guess as a young person, going through pregnancy, having children, I know that I have so many patients that they are they're fantastic. They go through it with no problem, but it's always a worry because things are a little bit more, you have to be really, really, really disciplined at that time. Now, also, I think everybody thinks about complication. The more you know about something, the more sometimes it worries you that, what if things happen? What if I can't see? What if I'm going to have nerve damage? What if I have heart disease? What that would mean for me as a physician, and how can I be there for my family? How can I be there for my parents if something happens to me, or for a partner, or as a mother, or all of that? So those are things that definitely cross my mind. And then on a day-to-day basis, you still worry about having those, having had diabetes for so long, having a low when you least expected, something bad happening, having a seizure, for example, even at work. So I guess those are the main things that comes to my mind.
Okay. And you just mentioned work, something happening at work. Can you tell us a story about work, maybe when you were seeing a patient, or giving a talk or a lecture or something where obviously something unexpected happened, and how you were able to adjust to what was going on and treat?
Yeah. So I guess you learn over time to plan. So every time, if I'm doing a talk, or if I'm somewhere that I know I won't be able to, kind of check my blood sugar, I would not eat carbs before, so that I don't need insulin, so that I don't need to be worried about being high or low. And then it has happened, for example, during residency, of being on call sometimes for 36 hours, not even having a chance to eat, to suddenly feeling like you're going to hit the floor, and having a low when someone is talking to you, and you're just dripping sweat and shaking from being low. But then you don't want to be that resident that says that, oh, wait a minute, I'm just going to go and get food. You just, try to push through it, and try to quickly find some kind of sugar and somewhere in the emergency room to eat, to go back to work again. So I would say my biggest challenge as a diabetic was during residency, just because you have to perform, you have to be on the ball, you have to not show any kind of weakness, you have to be there for other people. So there's no time to be there for yourself. So, and in long hours, not a lot of sleeping, sometimes even no access to food. So I would say that those were the most challenging times.
Okay. And to what extent have you been discriminated against? So you're a doctor, obviously, so you have a very prestigious, profession, but being type 1, can you remember times, either professionally or academically or personally, that you've been discriminated because you were type 1?
I wouldn't say discriminated, but I would, I guess when, when people know, like coworkers, and then they just sort of, and I think a lot of it, a lot of the times has been a positive thing, has been that out of care, just to make sure that they kind of be like, oh, did you forget to make sure you get your dinner, for example, before your call shift? Or, even a lot of the nurses would, if they knew, they would make sure they always have candy. Sometimes when I did my intense ICU training, so I wouldn't say discriminated, but sometimes I think, it's bound to happen that you feel judged, that you feel that maybe it's a disability, maybe that if that you're kind of looked at, yes, like, you're offering something, but at the same time, people kind of look at you differently, because it's considered a weakness. But that does happen, and I think it's almost impossible to go through entire life not feeling that way, whether it's from colleagues, or from friends, or even from family.
Okay. And question number 3, before I open it up to the other audience submitted questions, you might have already answered this, but if there's any additional points you want to make, what is your greatest fear about having type 1?
I think it's more the long term, I would say, complications, because no one has perfect, we're all bound to make mistakes, and things happen, and we know how it is with having diabetes for so long. So yeah, so they worry me. They're in the back of my mind. As I said, just for not just for myself, but also being able to be there for my patients and be able to be there for my family. So that's, I would say, is the biggest fear.
Okay. So we actually had a follow-up question from Katie when you were talking about your residency, and she asked, how did you manage those challenges when you were on residency?
So I think a lot of it is preparation. So maybe the first few calls I didn't know better. So, I went in, thinking it would be okay. And, just now then after a while, you kind of realize that, okay, this is your body's response to it. So, everybody's body would respond differently. But, for example, if you don't sleep, your blood sugars will be higher than usual. Or on the other hand, if you're not sleeping, but you're on your feet, you might need less insulin. So it's just adjusting that, making sure you eat before, making sure you have enough protein and fat before to be able to sustain your blood sugar. Hydration is really important throughout. And then really recovering after. So, after the first few times I did it, I learned that, it's all about, and as I said, diabetes is like a part-time job. You have to plan. You constantly have to plan everything you have to do. So then it was planning ahead before a challenging call shift and making sure that mentally, physically, I was ready for it.
Okay. All right. I'm going to move into some of the questions that were submitted by our audience. And again, I'll ask the questions. If you feel like they're medically related, you can go ahead and pass. The first one is from an anonymous person. How do you deal with assumptions and judgment from non-diabetics? For example, peers, family, colleagues, and even doctors regarding your diabetes?
I think it's a little bit different depending on uh, when you've had diabetes. So my experience has been that if you were diagnosed as a child, your maybe those assumptions are a little bit more. You feel it more, or you think about it more. For example, I have a lot of colleagues who are physicians, not endocrinologists, but they're physicians and have diabetes. And if let's say one of my good friends was diagnosed when he was 6, and when we're out, he's always under the assumption that everybody around him will know that he's injecting insulin. And so he would always have to leave and go to the bathroom. Whereas I was diagnosed at 21. So for me, I just inject at the table. And I've noticed that trend with my patients as well. It's sort of what you were used to. And so I think that's one of the biggest assumptions. Sometimes people see you out and you're checking your blood sugar, or you're giving insulin, or you're on a pump, and then they don't know what it is. And then I think it's just being comfortable with what you have and what you have to do. And at the end of the day, you have to do things for yourself and for your health. Sometimes it's about demystifying things for other people, whether it's educating your peers and colleagues about what it is, so that they don't judge and they understand it better, because sometimes assumptions is because of lack of knowledge about something. And then and then sometimes there are those unfortunate situations that people judge, and they think they don't think about it as a defect or a flaw. I think you just have to kind of walk away from that. It's sometimes a shame to have that, but I think that goes with a lot of other chronic illnesses as well. We just have to turn away from it and live our life the best we can.
I think one of the advantages that you have and I have is that being in medicine, people are much more understanding. I think they're much more tolerant. They try to learn a little about it. And outside of medicine, if you can, think of times outside of being with people who are in healthcare, are there times where you really feel like you're being singled out, or that you can tell that people are treating you or thinking about you differently?
Yes, sometimes like the non-medical, maybe there might be a little bit of that, but I find, I think most of the time I've been able to get through it by sort of demystifying it for people. Like if it was an issue, it just sort of, it's something that it's a new norm for me. So that's, my life would be different from, let's say, that person's life, but then this is how I have to do it. And it's just more kind of educating people about it. And that's what I've done in the past to deal with it.
Okay. A second part to the anonymous question: how do you remain positive when it feels so unfair to have to deal with this illness when it's inconvenient and expensive? I wish I could be carefree sometimes, but it requires constant management.
Oh, for sure. Yeah, definitely. And as I said, there's always good days and bad days. So yeah, I think everybody, including me, I have days that I feel like this is so unfair, having to think about it, having to manage it, sometimes failing at managing it. Things are very expensive, and a lot of the new things are not covered. So yes, it's for sure unfair. I think one thing to think about is that is to maybe take a step back and look at in comparison to other chronic problems, for example. And I guess maybe it is a little bit easier when you know or you see other people with other problems or other chronic problems, than you see what they're going through. So when I see patients that have multiple sclerosis, for example, and they're on very very aggressive medications with horrible side effects, that they're on wheelchair in their 30s, and that there's no cure, and there's even if they manage it, they go through pregnancies with difficulties. Then I would say, well, in perspective, comparing to that, and that's an autoimmune disease as well, and then maybe it's not that bad. Maybe and there's a lot of infrastructure research that's going through diabetes, especially type 1 diabetes right now. And I think when I see that there is a lot of hope there, I hope that this will be cured in our lifetime, and hope that even in comparing to 5 years ago, comparing to 10 years ago, even comparing to 2 years ago, how much the technology and medical field has improved in dealing with diabetes. That it helps for sure. I mean, even 10 years ago, if you walk in a dialysis ward, 9 out of 10 were type 1 or type 2 diabetics. Now you might only see 1 or 2. And the reason is diabetes is so well managed now. People, they seek out good doctors, they take care of themselves. And I think that gives us a glimpse of hope that we could have a normal life expectancy and have a good quality of life. Yes, with the frustration of having to manage things, but at least we could have a very good quality of life despite that.
Okay, we have a question from Alan. Do you have an exercise routine? And if so, how do you manage blood sugars, including pre, during, and post workouts?
So yes, I do. So I'm fairly active. Exercise and type 1 diabetes is a very interesting field. So it depends, I would say, on the type of exercise. So for example, exercise that's an aerobic exercise, which is a lot of cardiovascular training, let's say running or biking. So they tend to lower the blood sugar. So I usually eat something that's maybe 15 grams of carb and has enough protein and fat to sustain the blood sugar, and then give 30-40% less insulin, and then do the cardio workout, knowing that I will go lower during that workout. I usually have my meter with me if I go for a run or if I go for a long cardiovascular training, just in case if I feel off, that I'll be able to check my sugar. And then post cardio workout, also you tend to kind of go on a lower side, so you have to make sure you fuel yourself with protein. Anaerobic exercise, which is weight training, is the opposite. So people tend to go high during anaerobic exercise because you're using your big muscles and you're breaking down glycogen. So for example, hockey players, they tend to go high both from kind of the whole stimulus of being in the game, but also breaking down, like they're using their legs or breaking down huge muscles, or when you're doing huge heavy lifting, or things like spinning, for example. If you do it at high intensity, the blood sugar goes up. So in that situation, I actually have had a lot of trial and error. I know if I'm doing, let's say, weightlifting, I actually give insulin before to prevent the high, because I know if I go into that with a sugar of 7, I'll know I'll go to 13, 14 if I don't. So I know for me, I need to give 2-3 units of rapid insulin to go through the workout, and then later on I might have a low, so I'll make sure I eat after the workout.
Okay. Another question from Katie. Can you elaborate on that hope for a cure? In other words, new research. What is the newest research telling us?
Sure. So Dr. David Thompson and myself have been working on a stem cell trial for type 1 diabetes. It's been actually going on since 2016. The initial trial was done in San Diego, and that's to basically inject stem cells that will become pancreatic beta cells. So those are the cells that produce insulin. And it's been successful. So they actually become beta cells, they make insulin, so you become basically free of needing insulin. The problem with them has been that the autoimmune process that caused the diabetes to begin with will still attack those cells and over time destroy them. So the newest technology is to actually coat those cells with things that the antibodies can't attack. So, you know, from the way things are going now, the hope would be to be able to have this stem cell therapy without having to immunosuppress patients afterwards. Just because the immunosuppression that's used is a little bit harsh on the body. So even though you don't need insulin anymore, we still have to take these medications so that it doesn't come back. I would say the next set of trials that would happen in the next 2 or 3 years would be without immunosuppression, and hoping that we could maintain at least years as much as we can without insulin. And now even if it's 2-3 years without insulin, and then maybe sometimes going back of needing a little bit of insulin, it's better than nothing, not just because of less injections and less insulin need, but also in terms of complications, because a lot of studies have shown that if you're able to make your own insulin, your chances of getting complications are way lower.
In addition to stem cell and encapsulation research, is there any other type of research going on?
So there's still eyelid research going on. So the eyelid transplants are still happening everywhere. So we have a center in UBC. There's Edmonton is the biggest center, but there's still more research happening in the eyelid cell as well, so that they could do that without immune suppression as well. Now, so I would say the ultimate cure of this would be the stem cell therapy.
Okay. And what would someone have to do to qualify for, enrolling in a study like this?
So I think that keeps changing because the protocols keep changing. So the latest, so the protocol that was used before, the immune suppression is a little strong. So if you were under 30 and you were in a reproductive age, if you're planning pregnancy, or if you're planning having children, even for men, because it would affect the sperm, they wouldn't qualify. Or if they had diabetes and a lot of complications, they wouldn't qualify. So now the qualifications as of the trial that's coming is that if you're over 18, but not planning, you're not in a reproductive age, you're not planning an immediate pregnancy in the first year and have no complications of diabetes. But again, that is changing.
Okay. We have a question from Bernie. Have you tried CGM or pumping or both rather than having to do finger pricking, especially during cardio exercise?
Yeah, I've actually tried everything. So I was on all the pumps. I've tried Omnipod, I've tried Animas, I've tried Medtronic, and I have also tried the CGMs, the Freestyle Libre, the G6, and the CGM that comes with Medtronic, and the finger poking. So I would say that I'm right now, I do just the finger poking. I sometimes alternate. I find the CGMs are very useful when things are changing, or that you're not really figuring out what's going on with your blood sugars, because you'll be able to get a trend, you get a graph of where where things are not going right. Where are you under bolusing? Where's your basal needs to be adjusted? Or if let's say if you're sick, things are changing. If you're traveling, so at times of change that you want to titrate, I think they come really handy. Pregnancy is another time that it comes really handy. But if day-to-day basis things are pretty stable, You're having the odd, different spikes here and there, but majority of time things are good. Then I don't mind the finger poking, and I just stick to that. So because I try to have a lot of consistency on a day-to-day life. I try to eat the same thing most of the time, the same amount of carbs in the day. Stick to the same sort of exercise regime more or less. So majority of the time I don't use it, and I'm actually on injections. But I would say that for if you're having a lot of variability, it's very informative.
Okay. So a follow-up question to that. So you said you try to eat the same amount of carbs and try to keep a routine. But when you're, and not that this matters in COVID, but when you're on vacation, how are you able to maintain a routine?
Yeah, so no, vacation is definitely an exception. I would, definitely I would have times that I eat something that I've never had before, and you're guesstimating the carb and mess up and have a sugar of 17. It has happened. It does happen. But more I would say day-to-day basis. But definitely, I break the routines. Sometimes even during weekends or if I'm away. That you have to experiment, and I always encourage my patients to do that. You got to live your life. You got to experiment things, because that one spike in the blood sugar is not what's going to give you complication. It's all majority of the time. It's the day-to-day average that matters. Yeah. So yeah, I would say, and you learn. You try it, and the next time that you've made a mistake, and the more you learn about how your body responds to things, the better you can be at diabetes control.
So it's a good thing to experiment.
Definitely.
Another question, have you tried closed looping?
I have not. No. I know I have a lot of patients that do, but no, I have not done that.
What are your thoughts about closed looping?
I think it works well as long as people really know what to do and how to follow it. I have a lot of young patients with type 1 that they do really well using it. I find for myself, I thought the initial setup I had worked really well. I didn't really need to use the closed looping, but I usually just tell patients if it works for them, then I'm okay. I know some endocrinologists aren't okay with it, but if I find sometimes if the control is better and you're getting more consistency, then I would usually work with my patients to use that and help them titrate.
Okay. I'm going to go backwards a little. We have another question that was a follow-up from the stem cell transplantation and encapsulation. How long do you think it'll be until this type of treatment and the encapsulation and transplantation becomes widely available to the public?
I think it will really depend on how the next trial goes. If things go as smoothly as planned, I would say in the next 5 to 10 years.
Okay. And I have a question from Katie. This is that she submitted. Having type 1 and knowing this disease both by evidence-based knowledge and experiential knowledge, how does it affect your practice?
I think it has in a good way, because as I said, part of the reason I went into endocrinology was that I lived with. I really liked it, but also I'm interested in type 1 diabetes. I think it's very different experience when you're a patient. You're sitting in the same position as your patients, and if having had those experiences. So I hear a lot from my patients saying that I've told my family doctor I've had a low, and then they screamed at me, and they're like, "Why did you do this?" And it's just kind of the empathy and the understanding has helped me build a different relationship with my patients, be closer to them. I think understanding them a little bit better, and because I guess I know the challenges, and not to say that people that don't live with it don't understand the challenges. I think it's just it feels different when you're living with it as well. So I think it's helped. I actually have a big type 1 practice, so it definitely has affected it in a positive way.
Okay. Have you tried different types of diets? And if so, is there one that you've stuck to, or what is your food regime like?
So, I actually got very motivated by one of the patients I saw a few years ago who has had type 1 since he was 4, and very athletic, very active, and was basically eating very healthy, so no restriction kind of per se, and not like making starving himself, but a very kind of a good, I would say, a 50% protein, and maybe less than 10-15% carbohydrate, and the rest vegetables and fat, basically, a type of diet, and then maintain that consistency with all his meals throughout the day, and so was able to really maintain a good blood sugar. His blood sugar was, he actually had a CGM, and when you look at a CGM, he was always between 5 to 7. So I didn't have that. So I find consistency is really important. Not to say that you shouldn't experiment or live your life. I would say diet or regimes are terms that imply restriction. They imply kind of a change in your routine. I think it shouldn't be called that. It should be something that you're happy with, because you're going to be living like that forever. So if you like having a piece of pie at the end of the day, you just plan for it. You plan for it calorie wise, you plan for it insulin wise, you plan for it time wise. How long before your bedtime you're going to have it, so you don't have active insulin when you go to bed. How long you're going to do it between your dinner time and your dessert time. You just incorporate it into your life. I would say, personally, I think that's just my personality. I try to keep a consistent life, so I eat pretty regularly, and I would say fairly low carbohydrate diet, but that doesn't mean that that's the only diet. I think it's just more what works for you. And as I said, everything in diabetes control is about planning.
Okay. All right. Question from Anne. What are your thoughts about using time in target versus A1C as a measure of blood sugar control?
So that's actually more and more the trend. Reason being that, A1C was sort of invented as in the beginning because all the studies were based on it, and it's a good average. But as you all know, someone could have all like highs and lows, and on average the A1C might seem okay, but then if their sugars are running between 3 and then 15, that's not good. So I would say time and target is way more important than A1C at this point. And if your time and target is good, your A1C will follow. So if you're always, if your blood sugars are most of the time good and your A1C is not exactly 7%, but your time and target is where it should be, then that's what we want to see in terms of good diabetes control and preventing complications.
Okay. And a follow-up question from Anne. What are your thoughts about using Sglt2s with type 1s?
So, there's actually a lot of evidence for it in Europe, and then recently they are, since 2018, they've been used in type 1. I actually use it quite a bit. Now, it's just sort of the reason that there was a lot of hesitancy is because of a condition called diabetic euglycemic ketosis. So that's if you are not giving your insulin, or if you're sick, you could still make ketones, but your blood sugar will be falsely low because of these medication. So some patients got into trouble doing that because, let's say they were sick, they had ketones, they went to the hospital, but their blood sugar was only 11, 12 because of the SGLT2. So then they weren't treated as a DKA, and that was a problem. But I think a lot of patients, I tell them about that. I tell them that if you're sick, don't take it. If you're somewhere that's very warm, you're going to be dehydrated, don't take it. But if they know about it, it actually works, reduce your insulin doses, and also prevents big spikes after meals. So if used in the right combination, it actually works well.
Okay. And do you use the pump or MDI, and why?
So I use MDI now. I have tried all the pumps before. Personally, so as I said, I'm fairly active. I'm a runner, and I just didn't like having the pump on me when I was running. The control I find was very good with MDI, so then I just switched back to that, and I'm happy with that. But there's definitely advantages to being on the pump that you can't get with MDI, but it doesn't mean that you can have good control with MDI either.
Okay, and can you see yourself changing back to the pump at some point later in your life? I mean, so you obviously you would use the pump at some point, and does that change based on what's going on for you?
So I mean, I think one of the places that I would maybe consider, because as I said, right now, my lifestyle and what I eat is very consistent. So a pregnancy would be what time that I would definitely consider going on the pump, because the hormones are changing, your diet changes, your consumption of carbohydrate changes, you become more insulin resistant at times. So then the pump gives you a lot more flexibility that you can't really get with injections. And also the targets of blood sugars during pregnancy are very, very tight. And it's sometimes hard to achieve that with MDI. So that would be the time that I might consider switching.
And do you have any preferences with regard to pumps? Have you tried different pumps? And if you were to be on a pump, do you have a preference of which one?
So I have tried Animas, Omnipod, and Medtronic. I think all of them were different. They had good things and bad things. I personally liked the Omnipod because it was tubeless. And then the one thing that I always kind of was frustrated with the tubes is, again, running or doing active sports, it kind of start to get yank on things, or it was hard to sort of manage the tubing, and I didn't have that with Omnipod. So I thought that worked well for me.
Okay. Another follow-up from the time and target. What setting do you recommend for time and target for the low and high measurement? And what percentage would you like to see a patient in range?
So that the actual target really depends on the patient. So for example, if I'm seeing a patient who has really, really high blood sugars all the time, who's been diagnosed recently, then I wouldn't set it at a low target, because I want to kind of slowly lower that target. So for that person, I might even let their targets be between 10 to 12 or 10 to 13. Because if they're used to blood sugar of 20, then a blood sugar of 10 will feel like a low to them. They'll feel unwell. Whereas if someone is, really pretty well controlled and has had diabetes for some time, they know the carb counting and all that, then I would even set it as something as 3.8 or 3.8 to 7. That, kind of giving that aggressive sort of tight part of the low, so that knowing that the glycemic control is going to be tighter. So it really varies on a patient to patient basis. For example, another situation is if someone doesn't feel their lows, so they have hypoglycemia unawareness, then we might raise that target to maybe 5 instead of 3.8, so that they kind of don't go that low, and we eliminate it for some time. And in terms of percentage, so again, if you're a new person on the pump, initially it's sort of work in progress. So initially anything above 70% is perfect, but then over time we want to try to see 80%. If you get yourself to 85-90%, then that's excellent time and target.
Okay. Another follow-up from the SGLTs. How long does it take for SGLTs to clear your system? For example, you're sick, so stop taking them. How long after would your blood sugars better correlate with ketone production?
So usually a day or two. Most people, I would say by day 2 of not taking it, the blood sugars will start spiking as they would if you were off the SGLT2. So that's why if you're noticing that you're coming off with a cold, or you're getting sick, we recommend to stop it right away.
Okay. What about targets for after a meal? For example, 2 hours post-meal?
So again, if you want to be aggressive, ideally less than 8. But sometimes depending on the age, depending on how aggressive we want to be for the person. It could be also less than 10. In general, we want to try to keep values in the single digits, because we know that when blood sugars go above 12, that's when they start affecting the kidneys, the eyes, and the organs. So we want to, and I'm talking about 2-hour post, right? So if you're spiking to 13, 14, half an hour after you had a dessert, that's not, considered not in target. It's more once blood sugar stabilized, which is the 2 hours after. You want to be ideally less than 8, and again, if comorbidities or if hypoglycemia unawareness, less than 10.
Okay. I have a question from Jacob, a follow-up on the MDI discussion. What are the concerns with frequent injections in scar tissue and lipotrophy, hyperlipotrophy?
So the concern, it does, the more you inject at a spot, the more concerned that will happen. Now that's, that is a little bit genetics as well. So it's been shown that some people just make scar tissue and develop lipodystrophy more than others. There isn't really a correlation between the type of insulin you use. So now the type of insulin that was used in the past, which was pork insulin, bovine insulin, which is no longer really used, those were associated with more scar tissue, but those are almost unavailable. But if, again, recommendations to change the sites of your injection as much as you can, give that part a rest. Because, if it does develop after a while, there's different degrees. So if it's a mild, it might go away. But if it gets ignored and gets really severe, you might even require surgical removal of that part of tissue. So it could become pretty severe if ignored.
Okay, and a follow-up again from Jacob. Do you get different absorptions based on the time of day, area, etc.? How do you try and plan around this?
So the absorptions, so in general, the arm and the stomach area are the fastest areas of absorption. The buttocks and the legs are usually the slowest absorption. So basal insulin, which is the long-acting insulin, is usually given in the buttocks or the thigh area. And then the fast-acting could be the flanks, the stomach, or the arm. However, that being said, if you were to give yourself a fast-acting insulin in your legs and then go for a run, that's going to get absorbed really fast because you're running and you're using that, your muscles are burning and you're going to use up the insulin faster. Now, time of day, most people are most insulin resistant in the morning when they first wake up because their cortisol and their growth hormone is at its highest. So usually most people need a little bit more insulin in the morning. And then as the day goes by, it gets less. And now if you're more active during the day, also you're less insulin resistant. Heat really affects insulin absorption. So if you're in a warm climate, if it's sunny, sun and heat activates insulin faster. So insulin might start working in 10 minutes rather than 20 minutes. So people sometimes notice if they're on a beach vacation, they might notice that they go low faster or right after a meal that they didn't before because of the effect of the heat. So those are some of the things to think about.
Okay, I want to remind people it's 6:51, so we have about 9 minutes left because Dr. Moosavi needs to leave at 7. So if you have questions, again, go ahead and submit to the chat box or to Soraya. And while people are submitting questions, I'll just ask you, Dr. Moosavi, when everything with COVID started, as a person with type 1, how were you feeling? How did you react? And are there any recommendations or advice you'd give people with type 1 during the COVID crisis, even about anxiety and whether we should be anxious?
Yeah, I mean, for sure. I mean, it was definitely anxiety provoking for everybody. I think the common questions I got from my patients was, a lot of patients who had problems, from China or from Korea, they were patients with diabetes, so people were really scared about that. But what we know so far, recommendations are that people with diabetes are not at higher risk of getting COVID. Is that if they do get COVID exposure, the risk of developing complications of the infection, for example, pneumonia and all that, is a bit higher. And the more poorly controlled they are, the higher the blood sugars, the higher the chance. And that goes for any other illness too. So if someone has diabetes and gets any kind of influenza, their chances of getting sicker is more. So that's sort of been the recommendation.
So it seems like all the data that's coming out is on people with type 2. So do all the results pretty much apply to people with type 1 in terms of when the prognosis is worse, if you're poorly controlled? It doesn't matter if you're type 1 or type 2, it's the same.
Yeah, it should technically apply. I think it's a little bit skewed towards type 2 because they tend to be older population. There's a lot of type 1s that are younger. And then, sometimes comorbidities. So if they have type 2 diabetes and they already have heart disease and, lung injury, or if they have kidney problems, so then their chances of having problems or complications with COVID is higher. But that's not to say that someone with type 1 is less likely to have those things. It's the same kind of risk.
Okay. From Alan, I live in a smaller community that has no endocrinologist, and I was wondering if there is a solution similar to virtual GP visits for endocrinology. So for example, could someone see you who lives in Kelowna?
Absolutely, yeah. So I do virtual consults all the time. And usually once, we all work by referrals. So if you ask your GP to refer you to an endocrinologist, most of my colleagues do that as well. So we organize a virtual session, and then if my patients plan to, let's say, come into so my office is in North Vancouver. If they come into Vancouver, then we'll organize an in-person visit too. But actually with the whole COVID things, this has also been even more of a case because now we're doing a majority of our consults virtually. So I've been chatting with patients with type 1 diabetes and then consulting them and helping them titrate their insulin. It's we don't get to really touch them and do a physical exam, but at least we could help them kind of manage their diabetes during this time. So yeah, absolutely, virtual is definitely an option.
Okay. This is from an anonymous source. How do you keep yourself healthy with your mental health and your emotional health?
So I think a lot of it is, support is a big thing. So I think seeking support from people that that care about you. So I'm lucky. I have very supportive family and friends. So sometimes we all need to vent to them, and I do, and that helps. I think keeping active is definitely important because it's one of the only things you do for yourself. That's that when you're exercising, when you're doing something really good and positive for yourself. So that really helps me mentally. It's sort of, for me, it's like meditation. It starts off the day with the good positive energy, and not to say that I don't have low points. I definitely do. There's times that you get really overwhelmed and frustrated and sad about things, and you just have to sort of really feel all those things and really kind of be insightful about why you're feeling them and how to best deal with them, and what other people around you are dealing with that could be similar. And then you just sort of stay positive, and the next day is a new day.
Yeah, I would agree. What you just said about it's okay to feel those ways, and it's accepting those feelings. Only when you accept those feelings can you figure out what's the best way to deal with them, as opposed to trying to avoid those feelings. We have a question from Maureen. You raised your hand, Maureen. Did you want to unmute and ask a question?
Wait a sec. Yeah, I was just wondering what what the Sglt2 was, because I didn't know what they were, but I just Googled it.
Okay. All right.
Okay.
I have another question. This will probably be the last question. Speaking of insulin resistance, do you have any tips for decreasing morning insulin resistance in the morning? I have a hard time eating any carbs at all in the morning, even if I pre-bolus before breakfast.
So people on the pump tend to deal with this a bit better than on injection. So that's one of the advantages of being on the pump, because you could actually set your pump to give you more basal during that time that you're most insulin resistant. If you're not on the pump, then so I find sometimes it helps to give the long-acting insulin at bedtime, because even though long-acting insulin is 24 hours, it actually gives this first initial kick in the first 12 hours. So if you're having trouble in the morning, if you give it at bedtime, then more chances that, you know, it'll help in the morning to bring the blood sugars down. Also, insulin resistance is very much dependent on activity levels. So if you tend to do activities in the evening, the night before, and have lighter meals the night before, the liver response and the body's response in the morning is better. And one of the other things that I've noticed personally, and I tell my patients, this is caffeine. And so coffee, even if you don't put any cream, any sugar, will raise your blood sugar in the morning. So I have patients that tell me they have just a cup of coffee and the sugar just suddenly goes up for no reason. Is anything that stimulates your, you know, kind of increases your cortisol will increase your blood sugar as well. So sometimes you have to account for that if you're just having a cup of coffee or strong tea.
Okay, great. Any other questions? We have about 2 minutes left. I want to thank you, Dr. Moosavi, for carving out time to spend it with the huddle. I think it's great to have someone like you who obviously is so knowledgeable medically, but really understands personally what it's like. And I think just, you know, I know you as a friend, you're a very approachable, down-to-earth person. And so it's really wonderful to have someone like you to ask these questions, because I think at times patients do feel, or people do feel a little bit intimidated. So thank you again for taking an hour of your time tonight for talking with us. Thank you. All right. So those of you who wanted to stay after, feel free to. Hey, Jerry, is Jerry still? Yeah, you can stay after. All right. Thanks, Dr. Moosavi. Bye-bye.
Sure. Bye.
Yeah, so those of you who wanted to stay after to talk about anything, happy to field questions. If you have clinical questions or medical questions, Jerry's on the line. Jerry, our best nurse educator. If you want to talk about other mental health issues, coping issues, I'm happy to talk. Or if you guys want to just do kind of a traditional huddle session, happy, again, just raise your hand and I'll call on you because I can see your names. Okay, anyone? Okay, you don't have to. We just I wanted to make sure we had offered some time afterwards, like we did last week. So again, if you have any questions, clinical, medical questions, and you want to ask, Jerry is here and she's happy to answer. Again, if you have lifestyle questions, mental health questions, just want to talk about how things have been going for the past 3 weeks. Okay, yeah, hold on. Bernie, you can, do you want to unmute? Bernie, can you unmute? Oh.
Sorry, I was trying to figure it out.
Oh, no worries.
Actually, my question is for you, Dr. Tang. I sent it to Soraya. The previous doctor, Moosavi, she mentioned something about studies. Are there any new studies looking for candidates that a guy who's 55 and 35 years diagnosed now this spring could be a suitable candidate for?
There are a lot of studies going on in the division. Jerry actually works with Dr. Tom Elliott, and he's involved in probably at least 5 or 6 different clinical trials. So Jerry, do you have some clinical trials that Bernie, given his demographics, happens to be a good fit for?
Dr. Elliott, Tom Elliott, has a number of them going on and a number coming up. I would go on www.bcdiabetes and look at his clinical trials. If there's nothing that seems to be directly for you, Bernie, you can also call the office. Marla Indesil is the research director, and she might know of something that is coming available.
Yeah, and Bernie, if you want to just give me your, stats of your age and everything, I can just send it to everyone in the division. There are several faculty who are conducting studies and focus on very different things, some bone health, some thyroid, but I think there's a lot on diabetes. So if you just send me your background, I can send it to everyone and just say, here's someone interested in being involved in research. If they fits your criteria, happy to have them contact you.
I did the islet cell back in 2004, but the immunosuppressants weren't for me. So I gave it up, but I had faith in it, but I had to give it up after about a year.
Bernie, I want to thank you for your interest in it. It really takes some bravery, and it takes a lot of time. And as a mother of someone who lives with diabetes and as a nurse, I do thank you.
So how has everyone been doing for the past 3 or 4 weeks? I know some of you actually are not allowed to go to work and working from home. Some people may be still allowed to go into their buildings, but just wondering how things are going, because it's really tough isolating. There's a lot of things that change. Eating totally, I mean, maybe just for me, but I feel like eating habits, exercising has totally changed in the sense that there are no gyms open. You got to be really a little bit more creative. So is anyone experiencing those types of things? And does anyone have any, I guess, tips to share?
Loneliness is for sure for me, because my kids can't even come over to see me. But exercise has increased because I have a neighbor upstairs who works in the day. She's still able to work, so I take her dog out every day. It's best dog ever, and so because I don't have any pets, so that. But loneliness for sure. My own parents are scared to see me, and my sister. We do grocery shopping, but that's it. I mean, I don't have any fear of catching COVID. I don't think I'm in a worse position, to be honest. Like Dr. Moosavi mentioned, there should be no reason that you'd be more susceptible, but the loneliness amongst all my friends seems to be the number one thing.
So what have you done to try to stay connected?
Video chats, lots of video chats with my kids, even with my parents, even though they're 80 years old. They're getting the hang of it, and it helped them communicate with their family back at home in Italy. So it's not bad. Okay,
so like you, even though there is obvious loneliness, you've been able to kind of modify things by using Zoom and other platforms to talk. Anything else like creative? I mean, I know people are doing dinner parties on Zoom, playing games on Zoom, just seeing what other people are doing.
Have Easter or Passover on Zoom?
Katie, I see you nodding.
How was it?
It was a bit chaotic. we have a very large family, and we were all on there, and there's a lot of kids, and there was not any kind of muting going on. Everyone was talking all at once, but we all tried to be eating at the same time, and it was interesting, but definitely missing seeing everyone in person.
Yeah. What is it like having kids? With like in the sense that, like, what are you telling them? Because I feel like a lot of things, you know, you want your kids not to be scared, but you also want them to know that this is a serious situation. So how have you negotiated this whole situation with your kids?
Yeah, it's hard. We're also in the process of having to help him with homeschooling as well. You know, you try and explain it, but he's a very sensitive child, so he definitely has some concerns that usually come up right when he's supposed to be going to bed.
Yeah, no, I've been seeing a lot more resources for kids, like certain meditation just developed for kids. Hey, is that him? Hi.
He hears me talking about him.
I know. Anyone else? Does anyone else want to share? This is definitely the time, if you're feeling isolated, to just, you know, I think of this as a family. I like to see you guys in person more, but, you know, Zoom is, if that's our best option. Joyce? Oh, no, Carol.
Yeah.
Hi,
Hi.
Carol.
I've just noticed, because I'm not walking to the SkyTrain anymore, so I'm getting less exercise, and I'm not forcing myself out every day to walk. So I'm mad at myself. And also, because I'm home, the kitchen is right there, and I'm working right here. It's too close. So I tend to nibble a lot more.
Right.
So,
and so with the exercise, what's keeping you from going outside and taking a walk? I know you're saying that you're not doing it.
Just cause. I mean, I am walking, and I live on Royal Oak Hill going down to Marine. So no matter which way, I'm going to get exercise either going downhill or uphill one way.
Right.
But I don't know. I just can't force, I just not forcing myself out there, but, and not going to my run club. But I am staying connected because I've been working from home for 4 weeks now since March 16th. And I can connect directly to my computer at work so I can do my normal work. We have meetings on Zoom and Skype, and someone in my office organized a 3 o'clock coffee Skype every day. So if you want to call in on Skype for coffee, we just chat. Not about work. Usually about jigsaw puzzles.
Tips about staying motivated with exercise? Again, I know this is actually hard because I think a lot of people do belong to gyms, and now that they're closed, you know, I certainly am not someone who liked to run outside, and I kind of had to be forced to do it. But are there any creative things you're doing to make sure you get your exercise that you weren't doing before?
Katie?
So what I was doing, I live down at the New West Keys, so we have a boardwalk, and the challenge for me now that my son is home was getting out, but also getting him out. So we were doing, he would ride his bike and I would run. And that way we could keep a decent pace going, and it was working. However, this weekend they've now closed the boardwalk to cyclists, so we're trying to figure out if kids are included in that as well, and we're worried that maybe the boardwalk will close altogether, and that's our backyard. So that's a challenge. It's not a solution, I'm sorry.
Wait, but when that happens, do you have an anticipated solution?
I mean, we can go on the roads, right? It's a little more challenging, and that's what we will do. Or I'll just, I'll have to get up earlier and go by myself.
So what I do know is people are hosting free exercise sessions that they did on Zoom. If you'd like, we can get, you know, our research team to make a list of all the free exercise sessions that people are leading, and they range from yoga, meditation to probably more high impact type of exercises. But I'm, you know, again, I'm not sure if participating in like a Zoom exercise session would be something that you'd be interested in, but we're happy to, you know, collect all those resources and see. So I'm involved in different research. I'm involved in diabetes prevention for little kids, South Asian kids. So for that, one of our projects, we developed these Bhangra dance tapes, and Bhangra is like Bollywood aerobics. And so we have, you know, 6 of these 30-minute tapes of you know, instructors and little kids, like 8-year-old kids, learning different moves. And I know it sounds funny, but my husband and I have been doing that just because it's, you know, it's something to move, and like it's really high energy. But again, I would have never done that, do it myself if this hadn't, you know, happened. So that's one thing I would say I definitely move towards, doing things online or those types of sessions that I wouldn't have before. Anyone else have any recommendations of something they've done online or they've used that is interesting that Carol might be interested in? Because you really can't walk with friends. Because I was going to say, you know, you can't really ask a neighbor to walk because you're social distancing.
But you can do social distancing workouts.
Right. Like, I mean, do you have any recommendations of any workouts?
Like my brother and I are both seeing the same kinesiologist, and she's meeting us at a tennis court, and we're doing like a social distancing workout for an hour. And I just bring like my little weights and one of those bands, and she hosts the workout and she tells us what to do. And we kind of get to like hang out a bit that way too, because we're not really seeing each other. So yeah, it's good.
That sounds great.
Yeah.
So it's just the 3 of you. Oh, your instructor, you and your brother?
Yeah, but we're lucky because she's a kinesiologist, right?
Right.
So this is to do with an ICBC claim that happened before I got diagnosed, which is still going on. So we have it covered, but you could do it without kinesiologist, just social distancing workout outside. It's nice to get out and be with people.
Yeah, no, I agree. I think going outside once a day is so important, just to smell the fresh air, be in the fresh air, because you can easily just stay indoors because it's, I mean, easiest.
Yeah, it is what it is. Like, it's just so easy to, yeah.
But even going to the grocery store and making sure you're safe and washing your hands, but even that, going to the grocery store once a day is a routine. It's something you look forward to that gets you out.
Oh, I find the opposite with grocery shopping. It's been stressing me out. Like, I don't like it. Just.
Is it because of the crowds or like the potential dangers of?
Yeah, all of it. It's just weird. It's just strange. And I prefer to go like to small local places that have not as many people. Yeah. But yeah, it's just odd times right now.
So, in our face-to-face groups, I usually ask each person to answer a question. So I am going to, again, attempt this, and it'll be an easy question. But, and it's a question that I actually asked a bunch of my med students. Since COVID started, what's one thing you found yourself doing to make sure you weren't dying of boredom? Again, it doesn't have to be exercise, but what's one thing, or one thing you never did before this all started? And I will start saying, so Jerry, you have told me that the importance of washing hands and how long you have to wash your hands, and you had recommended singing happy birthday twice. And so I tried doing that, but it's just not really interesting to me. So then I decided, you know what, I'm going to pick a song that I like. And so I picked I Want a Hippopotamus for Christmas. So every time I wash my hands, I just say, I want a hippopotamus for Christmas. Only hippopotamus will do. I don't want a doll. And it lasts actually 24 seconds. So that is something I would have never done had the situation never emerged.
That's cute.
But no, really, it's like I didn't know the song as well also, but I would sing it just to make sure I finished it. And it was always over 24 seconds. But it's, I don't know, it's just something that's a little bit playful to do, but also making sure you're doing what you're supposed to. Anyone else willing to just raise their hand and say just one thing that they've done to make sure that they stay not bored? Nikki?
Super Nintendo.
Oh, Nintendo?
Yeah, I've been playing my Nintendo more.
Okay. Alan, Roy, Pam, Bruce, anyone?
Well, I think for myself, the only thing I can think of, I never really did it before. My wife always did it, but gardening.
Oh, yeah.
Yeah, so we actually went to the nursery on the weekend and learned about a bunch of different plants, and we started putting them all in. Like I said, I never did this before. I could have left it always to my wife to do that. So.
Yeah, and how crowded is it at the nursery?
It wasn't too bad. We went early morning, and there wasn't too many people around, so actually it was quite nice. I heard later in the day it got pretty crazy because a lot of people have the same thought that they wanted to start putting their gardens in, I guess.
Okay, and so what is one thing that you planted?
Oh, you're gonna test me now, are you?
I mean, like, are you like a flowers person or like a vegetable?
Well, yeah. So we live in an area that's very hot during the summer, so hot and dry. So in the interior of BC, so we always go with drought resistant type of plants. So we bought a bunch of those type of things. So like winter heather, those kind of type of plants that require little water, and I guess the one good thing is little maintenance as well.
Okay. Anyone else?
I've been doing a lot of binge watching, so that's why I'm happy to take the dog out for a walk. Yes.
So, top 2 favorite shows that you've been watched.
Ozark. I have to start season 3. It just came out, and Tiger King. Stupidest show ever, but I couldn't stop watching it.
But why is everyone so obsessed? You're right though. Like, it doesn't matter how old you are, young you are, what background you're from. Everyone is obsessed with the Tiger King.
it's amazing how stupid somebody could be. I guess that's the word I'm going to use, and how self-centered. You got to watch it. You know, it's well done. I have to admit, it's well done.
Yeah, no, I saw the first episode, and I was, you know, definitely amazed.
It gets better.
Ozark is addicting, though.
Yeah, Ozark is good.
Ozark's very good. Yeah.
Oh,
Hey, Jerry, I actually have a question from Roy. It says, could you please explain what glucose toxicity is in a recently diagnosed T1D?
I have heard that term before, and I believe that's when you're starting to go into ketoacidosis because your sugars are so high that you're unable to use them and you start burning off ketones. But glucose toxicity, you don't see that as a diagnosis very often. But usually it's when they're going into ketoacidosis and they need an ICU.
Okay. Roy?
I'll just jump in. Yeah, the reason I bring it up is that it's been a little bit hard for me to be diagnosed. I keep getting the determination that it's T1D or type 1, but the endocrinologist I've seen here in the interior said that in his report that there was a chance that it might be due to toxicity, glucose toxicity, that my C-peptide levels were so low in my initial testing. So I'm just curious what actually that means. It doesn't sound parallel to what you're describing, so I don't know if that's just like not understanding it, or I mean, Dr. Tang, have you heard of that before, glucose toxicity?
I haven't.
No. Okay.
I have, and just now I did a very minor search, and its insulin is very effective. It sounds like your beta cells aren't making very much insulin.
Well, that's just it. Yeah. So I've done 2 C-peptide tests, one initially, and then one with the glucose stimulus, where you're doing 75 milligrams of sugar, I guess, or grams of sugar. I can't remember. And both numbers, like the fasting one was below the threshold. So I was like basically saying I'm not producing any insulin. And then the second one was just inside the normal range when it was completely stimulated. So I've had another C-peptide test done actually just last week. So I'm really curious to see, because now, you know, when I presented with this, I was having an A1C over 10%, nearly 11% or something. And now the A1Cs came back at like 5.5. So, I mean, I have changed my diet quite a bit, and I've been exercising a lot, but the numbers are looking really, really good. So, I mean, obviously there's a little bit of hope for me in the sense that I'm always curious if there's any chance this could be type 2, and that I'll find that, you know, so when I see something like that from an endocrinologist, I'm just wondering if somebody could explain it. So I'll be talking to him again. So I guess that'll be who I ask.
Dr. Elliott is looking at the various types of diabetes, and I suspect that you will be told that you're a type that doesn't actually have a name yet.
Right.
You realize that there used to be basically 2 types, and then they kind of tacked on gestational into that. But we really know now type 1 is a variety of different types.
Yeah.
And you may find that you'll be given a name within a few years that doesn't really include glucose toxicity.
Yeah.
It's something more. And the reason that they need to tease all of these names out is because 1 or 2 treatments isn't enough. It's kind of a one size fits all, and we know how well that works. So that when we get a diagnosis, we'll know exactly what treatment. With glucose toxicity, insulin seems to be the only thing, but maybe if we know what type you have, maybe the Sglt2s, where it creams off the extra sugars, would be helpful for you as well. Right now, we don't know.
Yeah, that's interesting. I mean, that was the first time I've heard that term, and I was doing the same thing, a little Googling while we were in the meeting here, and could be interesting. Yeah. Well, thank you. Yeah, it's interesting too that, you know, I've heard the word LADA used a lot, but then once you come up here to Canada, it's like LADA is sort of this taboo thing where they're not trying to use it as much either. So it's confusing. It's just all very confusing to me. And it's only been a few months, you know, so.
It depends which area you're in, so that if you're in an area where the teaching hospital use LADA, you'll find that it's used quite a lot, whereas you come to see where UBC never uses it, so the physicians coming out don't use LADA.
I see.
Yeah, it depends. And there's a lot of different terminology that really, it's a mixed bag.
Mm-hmm. Okay.
So let me ask everyone, since you're here, what other types of guests or topics would you all be interested in talking about in the next huddles? So I had I invited Dr. Moosavi because everyone had said that it would be great to talk to someone who has type 1, but is also a health expert in type 1. We had Dr. Clayton come because he is an expert in physical activity and exercise. But what other topics would you all be interested in having guest speakers?
How about a nutritionist? I mean, I'm very curious about, you know, it seems to be there's another big, you know, large difference in what people recommend in terms of diet. So somebody who really has studied that thoroughly would be fascinating.
Okay, yeah, so we can bring a dietitian in, a diabetes educator with a specialization in nutrition.
Okay.
Any other topics?
I actually had one I wanted to bring up, which was I've been trying to find anybody that knows anything about strategies for the aging and type 1s. I don't know if you ever read anything from strategy and aging.
Okay, yep.
Sorry. I know that they're supposed to be working on one in BC, but I've never seen anything about it.
So someone who is an expert in aging issues or type 1 in the geriatric population, is that what you're interested in?
No, specifically type 1 diabetes and aging.
Oh, yeah, okay.
That's
Yeah.
what the interest is.
Yeah, no, I know someone who is an expert in that, Grady Manili, right, Jerry? Okay.
If it's of interest. It's interest for me.
We can do a special topics where if, you know, it's a special topic where people who are not interested in it don't have to sign up, but I think it's very important to be able to offer the different, you know, topics that people want. But thanks for letting me know. Anything else?
Yes, there was one other thing that sort of is associated with it. It has to do with the exercise and the fact that the COVID-19 and what it's done for me is that I exercise because I have to be able to keep walking. I can't go for a walk because I can't go very far. So the COVID-19 has shut down the YMCA, so I can't go there anymore.
Right.
It's shut down everywhere, and I can't even participate in the hospital now for therapy. So I was wondering if anybody ever knew anywhere that you could find some equipment that, like, I'm willing to walk in the store and see if I can rent that for an hour. Like, because there's no, I have to exercise, otherwise I can't walk. I'm at the point right now where I'm not walking. And that's just because I can't find any equipment to exercise on.
So I do know, at least in Vancouver, they're renting out spin companies, whatever. They're renting out their bikes for people. I do know that that's happening. I'm not sure about other fitness centers like Steve Nash, whether they're renting out their equipment. But what about doing sessions online? You know, where they have the.
I have those.
Okay.
To what extent? I have the aerobic stuff and everything. It's the legs.
I'm sorry?
I'm sorry, just to be specific, it's the legs. Very long-term neuropathy patient.
Okay.
And if I don't run the legs on like a recumbent bike or in the pool, I just don't walk after a couple of days. I have to do it regularly. And it's a very difficult thing to be able to do right now. And basically you end up to the point where you're just not mobilizing very well at all.
And you're not able to walk outside?
Short distance.
Okay.
But I couldn't, like, go around the block or something like that. It's just not going to happen. But it's a different thing after, by aging, it's, the neuropathy can really take over. And when it shuts down your muscle, instead of it just doing it gradually, it does it very quickly. And there's nothing you can do about it other than to keep exercising.
Yeah.
So it's a kind of a strange one. That's why I didn't really bring it up before, but it really does boil down to fitness facilities, fitness classes, the ones that I belonged to quite a few years, and go into 4 or 5 years, but nobody can come up with a solution of what can you do, because there's nothing available to work on. Like even a stationary bike. It's not the greatest one for me because I have a back problem as well, but it would help the legs. And recumbent's the best for me just because I have the neuropathy through the legs very bad, but I also have it up in my back and my shoulders and whatnot. So certain muscles there get help with about three times a week. Spend an hour on the bike each time. But it really keeps me moving. Generally keeps me moving.
You know what? Let me ask Dr. Clayton about that, because he specializes in exercise, and you know, we can ask him about the neuropathy question. So we're coming on 7:30, so we're going to close out. But if you have any other comments, any other suggestions for the next huddle, please just email us and let me know. But Roy will definitely talk to a dietitian and see if we can have a dietitian for the May huddle. And again, if anyone else wants to make a suggestion, happy to take the suggestion. Yeah, Nikki?
I just wanted to say that it was amazing having Mandana, an endocrinologist. Yeah.
She's great.
Yeah, she's so great. And just hearing from a specialist that also has type 1 was super cool.
Okay. And I mean, but would you like to hear from more specialists in general, even if they don't have type 1?
Oh yeah, of course.
Okay. Oh yeah, no, because I mean,
I was just saying it was a really good one.
no, and that's why I asked, because I knew, yeah, no, I mean, I really like Mandana a lot, and I do know that she's experienced everything you all talk about and that you've shared in group, and so I thought that'd be a great guest speaker. Okay, well, thanks everyone. We're going to close out now, but see you in about a month at the next huddle. And again, if you have any suggestions, please just let us know if there's anything we can do to help. I am going to have my team come up with a list of possible ways to exercise at home, you know, different videos that are free or different sessions people are hosting, because I do know for a fact that there are a lot of different yoga sessions that people are hosting, and if we can give you access, that would be great. Okay. All right. Thanks. Bye-bye.
Thank you.
Trisha.
Bye now.